So we have discussed the pathophysiology of heart failure, and it was a lot. Now we're going to go and take a look at the ways our patients present with heart failure and how we should be assessing them. The first step of our assessment should always be our interviews, asking our patients questions about how they feel and how are they doing. If our patient has right-sided heart failure, we need to be asking them questions related to peripheral edema. Have they noticed any edema or any swelling? How are their shoes fitting? Are they able to wear their rings? Have they noticed rapid weight gain? Do they feel like their abdomen is getting bigger? How is their appetite? Are they having any nausea? How much salt are they taking in? How much fluid are they taking in? Do they feel thirsty? And are they peeing a lot or a little? For left-sided failure, we want to focus on pulmonary issues. Are they able to be active like normal? Do they have any chest pain or discomfort? Do they have any cough? Any sputum? Do they have any difficulty laying down? Do they need more pillows to prop themselves up on? Are they getting short of breath when they move around? Are they peeing more at night? And then we need to notice if they're answering our questions appropriately and if they're oriented. This slide shows all of the ways heart failure can affect our head-to-toe assessment. Remember, our body works as one and not as individual body systems. Everything gets affected by heart failure. And you can see here, every single body system has something going on with them, and we need to be assessing that. Here's a picture of what the right-sided heart failure patient may look like. Notice those legs, notice that abdomen. The blood is pooling everywhere and causing everything to become edematous. This is what our typical left-sided heart failure patient will look like. Notice that tripod position he's sitting in to help him breathe. Notice that cyanosis of his fingers and toes and his mouth from the lack of oxygen. Notice him struggling to oxygenate his tissues. To diagnose heart failure, providers will start with the history and physical. This will include a lot of interview questions, just like we mentioned, and a head-to-toe assessment. The patient will have an electrocardiogram to see how the conductive system is working. They'll have a chest x-ray to see what the lungs look like. The patient will have an echocardiogram to check the ejection fraction, the structure of the heart, and how well the muscles are working in their heart. The patient may have a stress test to see how well the heart works while under stress. If in-depth diagnostics are required, the patient may have nuclear imaging to see the structures much more closely and in depth. The cardiologist may do a cardiac catheterization to see the exact stroke volume of the heart and to see if there are any blockages in the coronary arteries that may be causing the muscles to not get enough oxygen. Laboratory-wise, the provider will order electrolytes to make sure we don't have any imbalances, cardiac enzymes that check for muscle damage, and liver function test to see if the liver has any damage. They will also check the hemoglobin and hematocrit to make sure the patient has the ability to carry the oxygen to the tissues. Another lab they will draw is a BNP level. That's a beta type natriuretic peptide, BNP. This is that hormone that's secreted by the ventricles in response to fluid overload. This level will elevate with heart failure, and it elevates to different levels depending on the severity of heart failure. We can follow the trends of the results to treat our patients. In the ICU, I have seen results in the thousands for a BNP level because patients are in that bad of heart failure. All right, we've talked a lot about heart failure related topics. Now let's get to the nursing aspect. What is the nursing problem and what can we do for it? Heart failure is a multi-body system problem. These patients can have so many problems. I've listed some of them for you, some of the more common ones that you're going to see. They're listed in NANDA format, and even though NANDA isn't universal anymore, I did this so you can have specific names to look up in your ACLY book to help you develop interventions for your heart failure patients. Some of the problems our patients can have are impaired gas exchange due to the inability of the lungs to excrete CO2 and collect oxygen. We of course can have decreased cardiac output because the muscle is too weak. The patients may have fatigue or weakness, which may lead to activity intolerance. The patients will probably have fluid volume excess at some point in their heart failure diagnosis. These patients are also at high risk of depression, especially if they're younger. And every patient could use more knowledge on heart failure, the treatments, and the symptoms to watch out for. We do so much education in heart failure. All right, we know what the problems are. Let's see what we can do to fix them. The overall goal of heart failure treatment is to optimize hemodynamic regulation. What is that? Well, we need to make the heart work better, stronger, and more effectively to get oxygen blood where it belongs, into the tissues, and get excess fluid where it belongs, into the toilet. Doing these things should help improve the patient's symptoms and improve their quality of life. The medical management of heart failure is to increase cardiac output, reduce preload and/or afterload. Providers do this with several different types of medications, many times in multi-drug combinations. We can give patient oxygen to increase the amount of oxygen in the blood and therefore get more oxygen to the tissues. But don't forget, oxygen is a medication and it needs an order. We can also have them conserve their energy so they don't tire their body out and require more oxygen. We can administer diuretics to reduce preload, decreasing the amount of fluid being returned to the heart and get it where it belongs, out of the vessels, out of the tissues, and into the toilet. If we can decrease preload, we decrease the amount of blood in the ventricles, decrease the amount of stretch on the muscle, and hopefully allow the muscle to contract stronger. Got to think way back to Frank Starling's law again. We can administer ACE inhibitor or ARBs to decrease afterload. They both also decrease aldosterone production, which will decrease sodium retention and fluid retention. We can administer beta-adrenergic blockers or beta blockers to slow down the heart rate, make the heart contract with a little less force, and allow that muscle to get some more oxygen. We can administer digoxin to increase the strength of the heart contraction and improve the conduction through the cardiac conduction system. We can administer vasodilators to decrease the afterload in the body to make it easier for the heart to pump that blood out. We can administer anticoagulants to prevent blood clots in the periphery, like deep vein thrombosis or DVTs, or prevent blood clots in the ventricles themselves. Now, I made you guys a cardiac medications PowerPoint, and it is in the heart failure module in Canvas. There's a lot of information about all of these types of medications in there, and I highly suggest you look at it. It's going to be good for you for this semester and for all the rest of the blocks, and also for your career. When treating heart failure, we want to unload the heart fast. We want to sit them up, give them nitrates to dilate out the coronary arteries. Nitrates will dilate those coronary arteries out so we can get more blood flow and more oxygen to the heart muscle. We want to give them Lasix to remove any extra fluid they have. We give them oxygen. We give them ACE inhibitors to reduce their afterload. We give them digoxin to improve the contractility. We want to decrease the fluid that they take in, like a fluid restriction. We're going to give them medications to decrease their afterload, reduce their sodium intake to help prevent more excess fluid and edema, and we want to do our labs. The nice thing is some of our medications we can give these patients often do more than one job, but there are times where you will say your patients are taking beta blockers and digoxin and an ACE inhibitor, or they're taking an ARB, and we're giving them multiple medications at one time to get them to the best possible functioning they can with their heart. There are so many things we need to assess on our patients when it comes to heart failure, and we've touched on some of these already, but one we haven't discussed is daily weights. In the hospital, we must do daily weights on our heart failure patients. If they gain 1 kilo of weight overnight, that's equal to 1 liter of fluid they've kept in their vascular space or in their tissues. That is not good. If they lose 1 kilo overnight, then they've excreted a liter of excess fluid. That's really good, and we're making good progress. There are so many therapeutic interventions we can do for our patients, and this list is just a few. We need to sit our patients up. The higher we can get them to sit, the easier they can breathe. The chair is a great place for them if they can tolerate it, but we need to make sure we're watching their legs and their feet and their sacrum for dependent edema. We can administer oxygen as ordered to keep those oxygen sats up and to get them more oxygen to their tissues. We can ensure that the patient follows a low sodium diet and follows any fluid restrictions. We can make sure we help the patient conserve energy. Don't make them walk, take a shower, take their medications, and eat breakfast all at the same time. We need to space out our care. We're going to administer the medications as ordered. We can use compression devices such as TED hose and SCDs to help move the fluid from the tissues in the legs back into circulation. We can also elevate the arms to decrease swelling in the arms and hands. Range of motion exercises are also really good ways to get that fluid back into circulation. And with these patients, we need to remember our ABCs: airway, breathing, circulation. If the heart failure gets severe, this patient may need IV medications, intensive, invasive hemodynamic monitoring. They may need a pacemaker. They may even need a heart transplant. This is when that spiral to hell gets very bad and these patients end up in the ICU. Our heart failure patients always need education. Their treatments can change week by week when they aren't in the hospital, and they can change day by day or hour by hour when they're in the hospital. They need to know what's going on. They must be educated on the disease process, their medications, what symptoms to watch out for, and smoking cessation if they're a current smoker. Education is so important that the Joint Commission actually has heart failure as a core measure. That means hospitals get graded on how well they care for heart failure patients and how well we educate the patients. It's that important. We also need to educate our patients to avoid alcohol and NSAIDs. NSAIDs actually cause sodium retention and myocardial depression. NSAIDs make heart failure worse. The patients must be educated on low sodium diets and managing their fluid intake. They need to be educated on exercise and weight management because sometimes that will help reduce the stress on their heart, but only if they are healthy enough to do so. Some heart failure patients are so sick they can't do any activity. We're not going to make them start now. The patient must also be educated to notify their provider immediately if there is a 1 kilo or 2 pound weight gain overnight, or 2 kilos or 5 pounds in a week, or if they wake up suddenly with shortness of breath. We get really concerned when they gain that much fluid overnight, or if they have really bad shortness of breath that wakes them up, because we're hoping and praying that they're not getting into severe heart failure. If we're going to get these patients stable with their heart failure, they need to be able to follow their treatments they have ordered. Our best way of ensuring that is to educate, educate, educate. To end this discussion of heart failure, I wanted to touch on some things we need to consider when managing heart failure in the older adult. We have a very special population here in Arizona with our older adults, so it's really important that we discuss them. In older adults, confusion and restlessness can be the initial symptoms of heart failure due to lack of oxygen to the brain. Oftentimes, our older adults are taking the medications that treat heart failure for other reasons, so we don't see the typical heart failure symptoms until things get really bad. Older adults are also more prone to digoxin toxicity because their kidneys don't work as well anymore due to age. And digoxin is excreted by our kidneys, so we need to watch their kidney functions and we need to watch their digoxin levels. Older adults are also easily dehydrated from diuretic use because they don't drink as much liquid as younger patients. We also need to watch their potassium levels closely because remember, their kidneys aren't functioning normally anymore. Also, older adults are more susceptible to orthostatic hypotension from the medications they're on. This makes them fall risks. We need to watch them very closely when we start them on new medications or if we increase their dosages. And that concludes the final part of your heart failure lecture.